Hey everyone, welcome to our talk today. I'd like to welcome Dr. John Carrozzella. He's an orthopedic surgeon. He deals with sexual health. He deals with cardiovascular health. My kind of guy, Dr. Carrozzella. Thank you for coming on.
Thanks, it's a pleasure.
Dr. Carrozzella, give me your 76-second bio.
Well, I was originally trained as an orthopedic surgeon, did very well. I was exceptional at the top of my class. But I just felt that there was something not right about orthopedics. And when my ex-wife went through a dramatic menopause several years ago, I felt it was really exciting to get into preventative medicine, wellness, and then particularly hormones. And that led to a dramatic shift where I completely retrained with a master's degree. I have my certification through A4M here that we're at the meeting in Las Vegas, and have gone on to do hormones at an advanced world-class level to the point where now I educate internationally people in Italy and the European Union. I lecture nationally on topics of hormone wellness, preventative medicine, and particular area of interest that I have right now is preventive cardiology in terms of what people can do with hormones, supplements, nutritional management, and the results there are really remarkable when compared to what's available in conventional medicine.
Yeah, and it seems like you have one of the problems I have. We're addicted to learning.
Exactly.
Learning new things, right?
I love it. And, you know, I'll never forget back in the day when I first started doing hormone therapy, and I was just transitioning out of orthopedics into, you know, a medical specialty. And the answer always was more. And I just didn't like that answer. And so that scientist in me said, how do I do better at this? And it meant going back and educating. And of course, A4M has been fantastic in giving me that venue and allowing me to get a master's degree as something really special that really fulfilled that need for learning, something that I've just been on a quest to do ever since. So I love digging through the literature, learning and understanding, and be able to hold up an article that says, this is what the literature says, and that's really cool.
Awesome. Evidence-based, science-based. So
absolutely.
So tell me about cardiac wellness. How do you approach cardiac, or what did you call it? You called it cardiology?
Preventive cardiology.
Preventive cardiology.
Well, so, you know, I come from a family where two of my dad and my grandfather dropped dead from sudden cardiac death. And of course, that's the biggest issue. I mean, you know, anybody can diagnose a heart problem when someone comes in clutching their chest and they're sweaty and everything. They cath them and put a stent in. The big problem today is when we see people that are there playing golf on the third hole and drop dead for no apparent reason, and we go, well, how do we stop that? And, you know, when you look at the statistics for today in cardiac medicine, we were making progress in reducing cardiac death up until about 2010. And then all of a sudden, despite all of this technology, all of these new medicines, all of everything that we do, there's a big spike and an upturn in sudden cardiac death and cardiac problems. And they go, what's the problem with this? Well, the real answer is I don't think we've got our finger on the pulse of really what's going on. I think it's a greater and a bigger problem. I think some of the researchers like Mark Houston at A4M are doing a wonderful job in that area, but I think there's a lot more. And I think when you look at it, I think the key is to try to find those people that are at risk for dropping dead. And I think being in the hormone space allows you to do certain things with manipulation of testosterone, estradiol, and thyroid that allows you to get a handle on their metabolism, their sugars, their cholesterol metabolism, and then doing some things along the way that allow you to be more specific in picking up these people that are a particular cardiac risk. And I think that's evolving right now with things like a CT calcium scan, a CT angiogram, fractional flow analysis. And those things are going to be more sensitive and prove to be greater resources in diagnosing and preventing sudden cardiac death going forward.
So, Dr. John, tell me, how do patients end up seeing you for this preventive cardiology? Are they coming to you for something else and you just say, hey, while you're here, or do they look you up and say, hey, I really want to get my heart as healthy as possible? How do they usually end up in your office?
Well, you know, it's usually they're going to come to our office for usual hormonal health. You know they don't feel well. I'd say probably about 2/3 of the people that present in our office come there for the standard hormonal health kind of things, you know, libido, energy, focus, concentration, weight gain, and those things. And a few people do come for, you know, say, I know I'm off metabolically, I'm overweight, I know this is a problem. But they're not necessarily coming for cardiac preventative care. And so what ends up happening is we've developed a protocol in our office where we look at several specific evidence-based indicators of where people are going to go wrong, and we use those to guide us in a direction that will allow us to do the testing that's necessary to identify the people at risk. At meantime, we're working at fixing everything that we can, fixing that metabolic imbalance, those hormonal imbalances, those nutritional imbalances that are directly causative toward cardiovascular disease. So while we're working at fixing them metabolically, we're also identifying those at risk to the point where this year alone, we've identified 7 people that were either missed by their PCP or cardiologists that ended up having revascularization procedures of some sort when they were told, "You're fine, come back next year."
Yeah, it's a challenging thing to pick up and to find. Do you take care of men and women?
We
right?
take care of men and women. In our practice, it ends up being somewhere around 2/3, 1/3.
2/3 women, 1/3
Correct.
male?
Yeah.
Okay. So let's say let's go with a female patient. You have a female patient. She comes in and you are evaluating her for hormones, but also you realize that she's a risk. So how do you start? Let's go with hormones first. How do you optimize her hormones?
Well, certainly the first thing that we're going to do in the easy patient is that 53-year-old woman that comes in with hot flashes and night sweats. And they're, pretty much off of the start, what we're going to find out is that their hormones are imbalanced. I mean, I know hormone physiology down solid, and so I know they've got no estrogen, testosterone, thyroid is being insufficient, progesterone, and you know that those are high cardiovascular risk factors, and that a menopausal woman has 3 times the risk of developing heart disease as a premenopausal woman. So we know they're at risk to begin with. So the first thing that we want to do is make sure they're on a program that's rebalancing their estrogen, testosterone, and thyroid, which we know are directly cofactors with insulin and carbohydrate and cholesterol metabolism. And when you identify that, you start them on the road to correcting those metabolic parameters. And obviously, genetics and nutrition have a big role in all of this. And if they're genetically predisposed and having a poor nutrition, you're going to find out in their metabolic profile exactly where they are. And usually the 8 factors that we like to use are fasting blood sugar, fasting insulin, hemoglobin A1C, sex hormone binding globulin in the lower 50% of the range is highly indicative of insulin resistance. We know that a dyslipidemia with high cholesterol over 200, LDL above 90, triglycerides over 75, and particularly a triglyceride HDL ratio of 2.0 or greater. Those are high risk factors. And when you look at those 8 parameters, the more that they have and the greater that they're off, the more of an indicator that you're going to have of cardiovascular risk. And those are the ones that you're going to want to pursue in terms of identifying them with further testing to try to identify their cardiovascular risk.
What is sex hormone binding globulin?
Yeah, sex hormone binding globulin is a very interesting protein. It's manufactured in the liver. And what it does, it carries a lot of proteins, but basically it carries the sex hormones. And when there's a lot of sex hormone binding globulin, the effective levels of testosterone and estradiol will fall, meaning that you need higher serum levels in order to affect the results that you want. Now, a lot of people in the hormone world look at that as being a problem, that when your sex hormone binding globulin is high, it reduces the effectiveness of testosterone and estradiol. And that's 100% true. The problem is that when you have low sex hormone binding globulin, it's usually an indicator of insulin resistance, because when you're insulin resistant, you have high levels of blood sugar on average going forward over time, and it impairs the liver's ability to produce sex hormone binding globulin, so that level tends to fall. And you see the result of that with high levels of free testosterone, such as you might see in a woman who's got polycystic ovarian syndrome or something like that. So it's an association that when you have high levels of carbohydrate or dysglycemia or sugar regulatory problems, the liver is affected by that. It drops down the level of sex hormone binding globulin. And as an indicator, it shows you that you're a potential risk for insulin resistance and the things that go. It's actually a fairly strong indicator. So the lower it is, the more likely you're to be insulin resistant.
Right. And then the higher it is, if it's higher, then the woman is going to be more likely, or the man will be more likely to have lower testosterone, correct?
Well, then we get into the discussion between free and total, okay?
Right.
So the actual serum level really is become conventionally the one that we look at. But those who get really advanced in hormone therapy start to pay a little bit more attention to the free, because it's the free that actually exerts the impact and the effects upon the body.
Right.
So having free levels that are adequate to power the body's metabolic needs, that's what's important. So really, we want to look at the total. It's easy, it's simple, we're drawn to it, but really you have to understand that it's the free that impacts it. So understanding that relationship between the total and the free and the level of sex hormone binding globulin is crucial for a hormone practitioner to be able to really understand what they're trying to achieve and get that achievement, knowing that you're looking for effects more often than levels of the hormones. And so you get those levels by looking largely at the free.
I know low sex hormone binding globulin, there's research that shows that sleep apnea can cause that as well, which also increases your risk of cardiovascular disease. But for you are worried about as a risk factor, if that sex hormone binding globulin is low, it makes you go right to, let's take a look at insulin resistance, maybe sleep apnea.
Absolutely.
Right? You have a patient, she comes in, you see her sex hormone binding globulin is low. How do you check for insulin resistance?
Well, again, it's looking at the 8 parameters that I want to look at, okay? I mean, obviously, we were going to look at the waist circumference. I mean, a waist circumference of over 35 inches in a woman is pretty indicative, okay? That body dysmorphism is a real big problem when we see that shape abnormality. We're looking at visceral fat. On our in-body test, there's a range up to 25, and we consider anything over 4 abnormal and over 6 unacceptable, okay? So we're looking for visceral fat, and those are big indicators, okay? And then we go to our 8 parameters.
Well, let me just kind of comment. So visceral fat is the fat around the intestines, and the in-body you're talking about is actually a bioelectrical impedance test. It's a test where they send a current through your body, and you end up with numbers and calculations, and one of the things they can tell is how much fat and how much muscle and how much water and whatnot. So
absolutely,
you take a look at that. So you're taking at body composition. So go the other parameters of insulin resistance in particular that you're looking at.
Sure, we look at people that have sudden unexplained weight gain. So it's very typical. All of us who deal with hormones and watch women go through that perimenopausal transition, it's the same story. Well, doctor, I'm doing nothing different. I exercise the same. I work out the same. I eat the same. And all of a sudden I'm gaining weight. Well, that's a clear indicator of insulin resistance, usually hormone mediated, because as your insulin and your estradiol and your thyroid levels fall, or the effectiveness of those hormones fall, you develop a dysglycemia, a dyslipidemia as a result of the insulin resistant. And then looking at those 8 parameters that I mentioned earlier, those are very important indicators. And as the further off that they are and the more of those that are off, those are pretty good solid indicators of insulin resistance. And so we use those to direct our program.
So I want to be able to get into management and support during our talk. I know we don't have much time here today, but so we mentioned you mentioned visceral fat, you mentioned doing a body composition. Do they have abnormal weight gain? Do you want to just kind of shoot off what are the other parameters that you're going to look at, and then we can go right into how do you support it?
Absolutely. So usually it's a fasting blood sugar over 85. Well, the normal blood test is 100. It's a fasting insulin level over 5. I want the pancreas asleep after 12 hours of fasting. I want the hemoglobin A1C under 5.4. Many doctors look at 6.2. I think that is way too high. As I mentioned, the sex hormone binding globulin in the lower half of the range is indicative. My fasting lipid levels, I want my total cholesterol to be under 200, my LDL to be under 90. My triglycerides to be under 75. Well, I've heard some doctors talk about it wanting to be under 50 when they're fasting for 12 hours. I think that's a little bit strict when you look at everything together. And I think a very important one is a triglyceride HDL ratio of greater than 2.0. I think that has a lot of predictive capability in terms of predicting future cardiac events. So I look at those 8 parameters. And it's pretty much pass-fail. If you come in at 86, it's 86. Now, we can look at how many of those you fail on, and then we can start to look at the degree to give us a sense of how strongly you're insulin resistant. But, you get those parameters and you look at them and they're overweight and they've got a BMI of, 29, 30, 32, and their impedance testing is off. I mean, you're pretty solid that they got insulin resistance.
Nice. So you look at the parameters, the triglyceride HDL ratio, that's just a calculation they do with a regular cholesterol test, and you determine that they have insulin resistance and you want to really tackle that insulin resistance. So let's go maybe 1 minute over what lifestyle things are you going to start them with, and then maybe let's get into some supplements.
Sure.
All right.
Crucial. Lifestyle is absolutely essential. I mean, since we're insulin resistant, it means we've got an overload of sugar that the body's unable to handle, and it handles it by raising the insulin levels very high. It's determined by your genetics, it's determined by your metabolism, which is largely influenced by the hormones, and then it's determined by your nutrition. So on the lifestyle and nutritional side, we're looking for a rather strict program, and if the genetics are particularly poor, it's going to be even stricter. So we're looking at trying to keep your carbohydrate intake on a daily basis under 15% of your daily calories, and in something like a 1,500 calorie diet, that's around 70 grams, which can be really tight. We try to get people to eat all of their caloric intake within an 8-hour time frame. And for those who really get motivated, I like to try to see them achieve total fasting, a total 36-hour fast, 3 to 5 days a month. And if we can do that, they're really on a solid footing to get the nutritional and lifestyle support. A little bit of exercise is important, largely for cardiac health. I tell my patients you can't exercise yourself to thinness, and you can't exercise yourself to metabolic health. I'll give a little bit of credit to people that are training more than 8 to 10 hours a week, because indeed those people start to make some impact on their metabolism when they're training. But most people are not in the gym 8 to 10 hours a week, so they don't get a lot of credit for their exercise.
So really focus on food, their food plan.
Absolutely, food is medicine.
And this is just crazy. You're telling me that if they have a problem with sugar and too much sugar, decreasing sugar, don't just throw medicine at it. This is just weird stuff here.
Absolutely, absolutely.
So what is your, let's go maybe your favorite, if you had to pick 3 supplements to help with sugar control, what are your favorite 3?
Okay, well, I mean, I obviously like berberine. Berberine is a really good one for sugar control.
Yeah.
I also like chromium and cinnamon. I think that those are also very good for sugar control.
Nice.
Okay, and certainly along with that, making sure that the hormones are good and supplementing thyroid. Thyroid is crucial for insulin and sugar control. And there's volumes of literature written on thyroid in terms of it being a very crucial cofactor in sugar and metabolic control. So, vitamin D is very important, and that's becoming more and more understood as being a regulator. DHEA is another supplement that's very helpful in sugar and cholesterol control.
And let me ask you, so in this, so you work on their insulin resistance. In this program, do you do anything to help them boost nitric oxide?
Yeah, I love nitric oxide. I think nitric oxide is great for sexual health, and it's our primary go-to supplement. And almost anybody that complains of sexual dysfunction, whether it's particularly in male, but also in females. But the effects that nitric oxide is well known to have on vascular function and vascular pliability and flexibility is crucial. I mean, I take nitric oxide, and, my cardiologist is astounded at how my blood pressure keeps under control. He keeps wanting to talk to me about a second medicine. And, whenever he does, I amp up my nitric oxide, and my levels drop down about 5 or 10 points. And he goes, okay, I guess we don't have to have that discussion. But the nitric oxide is very good at keeping cardiac perfusion very good. And while it's not as necessarily, it's harder to put it in the preventative world, but it is in the, let's make sure that your cardiovascular system is working ideally. And particularly in those people that start to develop some calcifications and some vascular rigidity, trying to get them on nitric oxide is a crucial element, because you're reintroducing some flexibility into the vascular system, which takes pressure off of the heart and takes a stressor off that hopefully is going to lead to less cardiac events down the road.
So, Dr. John, I love that you love to think outside of the box, that you don't kind of stay limited to the box that they try to put you in, that you're evidence-based, that you're research-based. It sounds like you're doing some amazing work. How can people stay connected with you?
Well, I'm in Orlando, Florida, at the Florida Center for Hormones and Wellness, and our website is www.hormonesandwellness.com. It's very easy. It's hormones and what we do, wellness. Okay. And it's a great place to be. It's a great place to work. And we actually see people from all over the world and all over the country. And it's been a pleasure and an exciting journey to be on over the last few years I've been in this industry.
Social media, are you on social media?
Yes, we are. We can be found easily on Facebook and Instagram and most of the major social media venues.
And what do they look up on Instagram?
Hormones and Wellness.
Hormones and Wellness. Nice. Well, thank you very much for coming on, and I look forward to talking to you again soon.
Well, I appreciate it. It was an interesting, exciting discussion. I hope people find it useful.
Oh, they will. They will.
Outstanding.